Hi all. Let's talk about the most practical points of neuromuscular blocking agents. We all know that there is a plethora of information in your books and around, but let's talk only about those aspects which will help you conduct the case. What to do, what not to do. Let's get to the whiteboard.
Here we go. This is all you need for practically conducting the cases. And let's begin with what we are not dealing today. This classification of neuromuscular blockers, we're not dealing with that because whatever we are handling nowadays is either succinylcholine or the rest of them are vecuronium, atracurium, and the rocuronium. So except succinylcholine, all of them are intermediate acting, and succinylcholine is a short acting neuromuscular blockade. And the detailed classification we are not dealing here. Neuromuscular junction anatomy and physiology, how the nerve impulse is generated, how is it conducted across the synaptic cleft, the postsynaptic junctions, then the how is the ACH produced. We are not dealing here the structure of acetylcholine receptors, that alpha, beta, gamma, and those subunits of receptor. We are not dealing the sodium channel states, that is resting, activated, or inactive states. We are not dealing it here. Mevacurium, not practically important in India at most of the cases. Pancuronium, not. And the reversal agents, we're not dealing about neostigmin or sugammadex in this video. These are the topics. If you're looking for these topics, you can skip the video, you can exit right now. We'll actually talk about the most important drugs, which is the vicuronium, succinylcholine, rocuronium, and the atracurium. After dealing with the practical aspects of these four drugs, we'll also do the interactions of these drugs, the things which potentiate the effect of neuromuscular blockade, and the things which antagonize or decrease the effect. Then we'll deal with the scenarios like chronic kidney disease, what to do, CLD, chronic liver disease or liver failure patients, what to give and what not to give, in infants and in elderly patients, and also the seizure patients. Uh, these are gonna be the points that we're gonna cover. Let's talk about vicuronium bromide first. As you can see the ampule, this is a white colored powder. So it is not already present in a liquefied form. You cannot use it directly. That is why, because of this dry lyophilized form, you have to add some liquid. Now that liquid can either be 5% dextrose or normal saline. Remember, ringer lactate or other fluids are usually not used for reconstituting most of those dry formed drugs, especially vecuronium. So you can either use 5% dextrose or the normal saline. This ampule contains 4 mg of vecuronium bromide. Remember this full name, lyophilized form. You always check the expiry date of the drug, as we know that this is a non-depolarizing neuromuscular blocker. What does that mean? There's competitive antagonism at the post-junctional nicotinic acetylcholine receptors. As we know that once acetylcholine is released, it attaches to the postsynaptic receptors, which are the ACH receptors, and then the calcium releases and your contraction occurs. So this will be the electrical and contraction coupling. This is going to go and bind to these acetylcholine receptors and inhibit the neuromuscular transmission. This was, in summary, the action of the non-depolarizing neuromuscular blocker. Then the vecuronium, we mostly use it for prior to the intubation of normal patients, because this is the most widely available drug and quite cheap. So we are using it quite often, and also the duration of action is much more as compared to succinylcholine, atracurium. So that is why we need not repeat it too frequently as compared to the other drugs. This is the reason why we are using vecuronium nowadays in our OT most frequently. The intubating dose is 0.08 to 0.1. If you can't remember two values, just remember 0.1 mg per kg of body weight. What does that mean? 0.1 into, suppose the patient age uh, weight is 60 kg, so you're gonna give 6 mg, or after dilution, that means you'll be giving 6 ml. Now, how do you get that 6 ml? One ampule contains 4 mg, so you have to actually break two ampules, that means 8 mg, and add it with 8 ml of NS or 5% dextrose. That will form your 8 ml, because it's a 8 mg is only dry form. Out of this 8 ml, you have to give 6 ml, provided the patient is 60 kg, and keeping the dose as 0.1 mg per kg. After giving vecuronium, remember this is very important step, that you have to make sure that you are able to ventilate the patient after giving the induction agent, that is propofol, etomidate, or ketamine, whatever you're giving as induction agent. After you have given the induction agent, you have to confirm that you can ventilate the patient by bag mask ventilation. You have to close the APL valve and ventilate, because if you are not able to do that, and if you give the muscle relaxant prior to confirming, that can be a bizarre, because the duration, you can see here, the duration of vecuronium bromide is 30 to 40 minutes. And if you're not able to intubate, uh, and if you're not able to ventilate because you have not checked it, then you will be in serious trouble, because you can't ventilate and then you can intubate. This can become a CICU condition, and then you have to go for front of neck access, and that's going to be a bizarre situation. Once you have confirmed the ventilation after the induction agent, then we give the induction dose of vecuronium. Suppose now you have given vecuronium 0.1. So it will take some time for the vocal cord movements to subside. All those skeletal muscles that have been paralyzed, the diaphragm is paralyzed, all those, that will take 3 minutes. So at least 3 minutes. You have to wait for 3 to 4 minutes. Sometimes people wait even more, because not all drugs have equal efficacy. So you have to wait minimum 3 minutes and have to ventilate the patient uh, by your own efforts. After those 3 minutes, then do your laryngoscopy and intubate. Now we know the duration is 30 to 40 minutes. That means you have to then repeat the dose. Now, what should be the dose of when you repeat it? 0.1 mg was the loading dose. Then the 1/4 or 1/5 of this dose has to be the maintenance boluses. For example, you gave 6 mg to a patient, then you can easily repeat 1 to 2 mg every time once your patient is coming out of the effect. Now, how to check whether the patient has come out of the effect is by your end tidal CO2. There are curare notch, and there are other signs like increase in heart rate and blood pressure. The patient may even actually start moving, or he may buck on the tube. All those signs you can see. And the gold standard for checking is your neuromuscular monitoring. So the TOF ratio that you see, TOF count and TOF ratio, which is in itself a big topic, you have to check on the basis of that TOF, when is the time you can repeat your maintenance bolus. So here we go with the bolus, and here we are done with the maintenance. Let's talk about the metabolism. It is metabolized by liver, and it is extrahepatic metabolism is 20%. Then excretion is by hepatic and extrahepatic pathway. It is excreted in the urine itself also. So you can see that it has a mixture of metabolism and excretion from hepatic and non-hepatic pathways. That means it is not absolutely contraindicated. We'll look at the scenario of chronic liver disease and chronic kidney disease, that vecuronium, even though it is metabolized and excreted, a major part of it is excreted and metabolized by liver, it still is not absolutely contraindicated in these situations, because some amount is still metabolized from extrahepatic pathways. So we'll talk about those scenarios in a while. Then it is a cardiostable drug, very important, because you'll be intubating a lot of patients in emergencies and all. And you can see that being a cardiostable agent, there's not much of hemodynamic fluctuation, so you can safely administer vecuronium in those patients. Unlike pancuronium, I'm just comparing pancuronium, we are not using it routinely, but for pancuronium, just remember it is a vagolytic agent and it will cause tachycardia and hypertension. Even though it is more potent than vecuronium, but it will cause that tachycardia and hypertension, which may be detrimental to a lot of patients. In the ICU, and if you're doing long cases, for example, you're doing a plastic surgery case which will take 10 hours or 12 hours, and you're doing neurosurgery case, in those cases you can't keep on repeating those vecuronium boluses. You're not using routinely the TOF monitoring, you're that neuromuscular blocking, you're monitoring that you're not using routinely, so you can't keep on repeating or focusing on repeating it every 30 minutes or 40 minutes, and still may the patient may be coming out too frequently, or maybe you are repeating it too frequently and the patient may not come out later. So to avoid that, we have to give infusions. After the bolus dose of 0.1 mg per kg, you have to follow it by an infusion by using your those infusion pumps. To remember it, the point 0.1 is the bolus and 0.1 mg per kg per hour is this infusion rate, but this is actually quite high, on the higher side. That to be very precise, the dose is this: zero point 0.8 to 1.2 microgram per kg per minute. Let me tell you an example. Suppose the patient is a 60 kg man. So with 0.8 into 60 kg into per minute, you have to convert into per hour, because the infusion pump you are setting there, the rate that you are setting has to be per hour. So this has to multiply by 60. It will be 2.8 mg per hour. So you have to adjust on the infusion pump 2.8 as the rate for the infusion, and if you take it as 1.2, then it will be 4.3. So for a 60 kg man, you can set the rate in between 2.8 to 4.3. If you take something in between, that is 3. So if you set the 3 ml rate, these are the usual rate that you set for a neuro patients or those patients in which you don't want to repeat the boluses. So 3 ml is very safe limit. If you want to be very sure that patient is should not move at all, so you can increase it to 4 or 5 ml per hour rate. So this is the most practical point that I want to administer. And this 0.1 mg per kg, obviously this is a higher, the maximum rate that you can set. Let's move on to the next drug, which is succinylcholine. Now the succinylcholine is comes in 50 mg per ml of liquid. It comes in the amber colored bottle, and usually in the 2 ml ampules, and you don't have to dilute it. You just have to uh, pick it up in a 2 ml syringe and then give it to the patient directly. And most of time, because it is used as a part of rapid sequence induction, so you just have to give it to the patient just immediately after the induction agent, so that you can intubate the patient very rapidly. And because the onset is quite quick, within 60 seconds the effect comes, so that is why it is used in a part as a part of RSI. The mechanism of action is, it is a persistent depolarization of the motor end plate. And remember, it is not metabolized by acetylcholinesterase, it is metabolized by pseudocholinesterase, which is present in the plasma. So if the patient is genetically having less amount of pseudocholinesterase, or it is having what is known as atypical form of this pseudocholinesterase, it may be a possibility that the effect will persist. Usual duration is 6 to 10 minutes only, but if you have this atypical pseudocholinesterase, that means the succinylcholine is not going to be metabolized, and the duration is going to last even in several minutes or several hours. So you have to keep ventilating the patient electively till the patient comes out of this effect. There is one more situation when this duration increases. Now this is known as your phase 2 blockade. When does this occur is when you give a higher dose of single dose of more than 4 mg per kg, or you are giving repeated doses mostly in higher dose, 7 to 10 mg per kg in total you have given, or you have started some infusion of succinylcholine. Those are the points that can lead to phase 2 blockade. This phase 2 blockade is very similar to neuromuscular blockade of non-depolarizing type, so it will take several hours for the patient to come out of the effect of succinylcholine. This was about the duration, that you have to be very sure that they have to rule out several other causes of why the patient is not coming out of the effect, because it may be hypothermic. There are other several causes of the patient not coming out of the endotracheal tube, or he's not able to breathe on his own. One of those causes is atypical pseudocholinesterase and this phase 2 blockade. So you usually have to keep it in mind that these are the other two reasons of why the patient is not coming out of the effect of neuromuscular blockade if you have given succinylcholine. The dose is 1 to 1.5 mg per kg of body weight. In infants, because of higher blood volume, it is higher, on the higher side, 2 mg per kg. The use is rapid sequence induction, difficult airway. In electroconvulsive therapy, there you give it, and in post extubation laryngospasm. But the dose in this laryngospasm is 0.5 mg per kg. There is an algorithm for laryngospasm, that there are certain maneuvers, jaw thrust, then you have maneuvers to break the spasm. If you're not able to break the spasm, then you have to administer certain drugs, you have to deepen the anesthesia, and you have to remove the trigger of the spasm. But if you're not able to do it, succinylcholine in a dose of 0.5 mg per kg can be given to break the spasm. So this was about the major indications and the doses of succinylcholine. Remember, it is never given in infusion forms. Hardly there's some clinical situation where you're giving it in infusion, but it is not supported by most of the people as infusion form. The side effect, the most important being the elevated potassium. So in whatever situation you are thinking of giving succinylcholine, you have to see whether potassium is on the higher side, and it increases, a single dose of succinylcholine can increase the potassium by 0.3 to 0.5 mg milliequivalent per liter, which may be insignificant in patients. Suppose we have a normal side, the potassium is on the normal side. Even if it increases by 0.5 milliequivalent per liter, and it increases only transiently, so that is not going to affect. But the patient, suppose, is a case of chronic kidney disease, or suppose the patient is of burns, or there was some denervation hypersensitivity. In those cases, we have increased extrajunctional receptors, and those extrajunctional receptors will lead to release of a lot of potassium, much more than this 0.5 milliequivalent per liter. So in and suppose a patient is chronic kidney disease, in that patient the potassium is not getting excreted from the body, it accumulates. There's hyperkalemia in CKD patients. So you should have to avoid succinylcholine in these patients. Considering the burns, burns in itself is a big topic in anesthesia, but remember, in respect to succinylcholine, you should avoid giving succinylcholine in a burns patient if if it is an acute burn of less than 48 hours, that is less than 2 days, and suppose the 2 days have passed, then less than 2 days, you can give the succinylcholine. But if suppose 2 days have passed, you should avoid giving succinylcholine. And for 2 years now, so this history of burns is important. For 2 years, you should not use succinylcholine, because that can lead to a lot of hyperkalemia. After 2 years, you can use it. Then after the potassium, we move on to the intraocular pressure. So you should be avoiding those succinylcholine in uh, eye trauma patients, or cataract surgery, or glaucoma patients. In ICP, it increases the ICP, so succinylcholine is avoided in neurosurgery patients, or the patients having increased intracranial pressures, and the gastric pressure, which is also increased, however not very significant. But remember, these all of these effects, increase IOP, increase in ICP, or increase in gastric pressures, they are mostly because of the fasciculations. So the fasciculations of succinylcholine is something that you should try to inhibit. We will see in a while how to inhibit those fasciculations, but this is because of those muscle contractions that you see after giving succinylcholine, which will lead to increase in these pressures. As you know, succinylcholine is very similar in structure to acetylcholine. So in CVS, you can see that it leads to bradycardia most of the time. So suppose in emergency you are going to give succinylcholine and the patient is already bradycardic. Suppose the heart rate is 40. You should try to avoid succinylcholine and use some alternative as RSI, that is rocuronium. So rocuronium will be much better in a patient of bradycardia. And also obviously a patient of bradycardia, if you want to intubate, avoid succinylcholine and give some anticholinergic along with it. Suppose give glycopyrrolate or atropine along with it. So don't intubate in a bradycardic patient unless you give these drugs, and try to avoid succinylcholine. The second thing is, it can also cause tachycardia. In very rare conditions, when you're giving a very high dose of succinylcholine, it can actually stimulate ANS ganglion, and which can lead to a lot of tachycardia and arrhythmias. Very rare, but this is a possibility with higher doses of succinylcholine. Then you can have myalgia because of those muscular fasciculations. In young and minor surgeries, this will be the major problem. If you have given succinylcholine and after surgery, after you have extubated the patient is complaining of muscle pain. So this may be a side effect of succinylcholine. Then a very important side effect is masseter spasm, which may point towards the possibility of malignant hypothermia. Now this malignant masseter spasm, this is the face and these are the masseter muscles. If they get into spasm, your mouth opening will be restricted. It is actually completely blocked mouth. So your ventilation and even laryngoscopy, you can't open the mouth. If you're not able to ventilate and you're not able to open the mouth, you can't do laryngoscopy, so intubation is gonna hamper. So this masseter spasm can be a very detrimental thing in a lot of emergency situations when you have given succinylcholine. Phase 2 blockade we have already talked about. Let's talk about how do you actually reduce those fasciculations and subsequently those consequences of those fasciculations, which is raised IOP, ICP, or intragastric pressure. It is priming and pre-curization. What is priming? You give 1/10 dose of neuromuscular blockade, non-depolarizing. Suppose you're giving vecuronium in 1/10, that is loading dose is 0.1 for vecuronium. If you're giving divided by 10, that is 0.01 mg per kg. If you give this dose of vecuronium or rocuronium or atracurium, that means the 10th 1/10th dose of any of those non-depolarizing agent, and then you wait for 3 minutes, so the fasciculations are not gonna come. Effect of succinylcholine will come, the duration is gonna remain same, but the fasciculations will not come. So those side effects are actually prevented. This is known as priming. And because of this, the phenomena which occurs is pre-curization, which will reduce the fasciculations and those increase in all the pressures. These were the side effects, most important side effects. I just want to talk about intermittent Scoline IMS also. This is a new concept, and no one in most of those government hospitals are using it because of the risk of phase 2 blockade. We know that we should not repeat the dose of succinylcholine because of the risk of phase 2 blockade. So the patient will have prolonged duration of succinylcholine. But it is seen that if you are using very small doses of succinylcholine for repeating, you can use this intermittent Scoline IMS for very short procedures. Very short procedures you can do this. Suppose the surgeon wants muscle relaxation, but you don't want to give some longer acting muscle relaxant. You want to save the time in between cases. There are multiple cases and all of them require muscle relaxation. So at that time you can use this preparation called intermittent Scoline IMS, where you add 2 ml of Scoline, that is 100 mg, and then add atropine or glycopyrrolate along with it, because this will avoid the bradycardia because of the succinylcholine. And then you actually dilute it to 10 ml of NS. You can give 1 ml of NS to maintain the muscle relaxation, and because this is gonna come, the patient is going to come out very rapidly, so the time for extubation reduces drastically. So this is a very new upcoming thing that I wanted to tell you guys. The next drug is rocuronium. Rocuronium is a very good substitute of succinylcholine. It comes in a clear liquid formulation, unlike vecuronium. And the preparation consists 10 ml 100 mg, that means 10 mg per ml. And this is a multi-dose vial, and the concentration is this. Classification is again this intermediate acting drug, and the dose is the most important thing, zero point 0.1 to 1.2. Why is there such a wide range of this dose? Because it is having a dose dependent action. If you're giving it very similar to the vecuronium, that means you have time, that means you have 3 minutes for intubation, then you can give it with a dose of 0.6 mg per kg. And suppose if you want to do it RSI as an alternative to succinylcholine to intubate within 60 seconds, then you have to give rocuronium at a dose of 1.2 mg per kg. Metabolism is primarily hepatic. So as I told you, in a clinical scenario where a patient is chronic liver disease, is having chronic liver disease, rocuronium should be avoided altogether. Vecuronium can be used, but how it can be used, that I'll tell you. But rocuronium should be avoided in chronic liver disease or hepatic failure cases. Let's talk about the last drug of today, that is atracurium. It comes in these ampules which are 2.5 ml, and it consists of 25 mg. That means very similar to rocket, that is 10 mg per ml. This is the concentration. The best part with atracurium that it is not dependent on other organs for its metabolism and excretion. So it has its own Hoffman elimination, which is a non-enzymatic chemical degradation, which is pH and temperature dependent. And that is very important, because in atracurium, ampules has to be kept in fridge, and they have to be kept and at much lower temperatures as compared to the other muscle relaxants. So atracurium should be used in fresh form from fridge, so the effect is better or more pronounced. It is having aster hydrolysis, so it has some independent Hoffman elimination, which will help you administer it in whatever failure the patient is, maybe liver failure or kidney failure. Uh, it can be easily or safely administered in these patients. But side effect is that it releases histamine, very similar to morphine that we use in anesthesia, or atracurium is another drug which releases histamine. And because of this histamine release, what side effects do you think will happen? It will lead to vasodilatation, so the blood pressure may fall. It may lead to reflex tachycardia. Because of this hypotension, it may lead to tachycardia. And the most deadly complication because of this histamine is bronchoconstriction. So bronchospasm may be a result after you have given atracurium. How do you avoid then this? How do you avoid such a massive release of histamine from after giving atracurium? You have to give it slow. So slow administration, approximately in, if you give atracurium, give it over 60 seconds slowly, and that slow administration will lead to decrease in these side effects. So this was the reduced by slow administration. Or you can give some antihistaminic drug, some H1 or H2 blocker you can give prior giving this atracurium, which will tell you that this should be contraindicated in patients which are already having propensity of bronchoconstriction. So you have to avoid it in asthmatic patients. Another thing about this is lodanosine. This is a metabolism which is excreted in bile salts, and it decreases the seizure threshold. Very practical point, that in patients of suppose renal failure or liver failure, in those patients, if you give atracurium is going to be metabolized. There is no problem with patient coming out of the muscle relaxation. But what about this metabolism, this lodanosine? Because this may accumulate, and this will lead to decrease in seizure threshold. And the patients who are predisposed to seizure, that is suppose eclampsia or pre-eclampsia patients, they will have seizure post atracurium administration. The dose induction dose is 0.5 mg per kg, and very similar to the VEC, the maintenance dose has to be 1/4 or 1/5 That means it will be approximately 0.1 mg per kg of body weight. It will be the maintenance dose. And how when are you going to repeat this dose is 20 to 30 minutes, which is much less than vecuronium. Onset is very similar to vec, which is 3 minutes. Suppose you want to give infusion of atracurium in ICU or long cases. For example, there is a patient of chronic kidney disease, and now the patient is for neurosurgery. So you will restrict the fluids, IV fluids, because of the fluid overload the patient has. Along with that, you will avoid using vecuronium or rocuronium because they are metabolized and then excreted by this kidney. So you'll use atracurium or cis atracurium, and you'll use the infusion in this dose, very similar to the induction dose, that is zero point 0.5. The maintenance infusion dose is 0.4 to 0.5 mg per kg per hour. This leads us to a bit about cis atracurium. You should just remember that the dose is 0.1 mg per kg. That is equivalent to the vecuronium dose that we have read. So cis atracurium is 0.1 mg per kg, but atracurium is 0.5 mg per kg. It is not regularly used, but just remember that it is a highly potent drug, 3 times more potent than atracurium, and the duration is equivalent to vecuronium. But it is very expensive. It leads to lesser histamine release, lesser laudanosine production, and no dose adjustment is required in renal, liver, or cardiac patients. After we do this, let's talk about the interactions quickly. If you're using volatile agents like desflurane, sevoflurane in a surgery, which we usually use, in those patients, if you're giving muscle relaxation, these volatile agents will prolong the action. So the need for repeating the dose will reduce in comparison to, suppose if you're using TIVA, that is total intravenous anesthesia, where you're not using inhalational agents also. There you have to repeat the muscle relaxant more frequently. Similar to that, if you're giving local anesthetics in intravenous route mostly, suppose you're giving plain lignocaine, xylocard 2%. If you're giving in IV form for suppose antiarrhythmic action, or if you're giving it as a part of analgesia, we know that multimodal analgesia, we give PCM, we add lignocaine 2%. A lot of people do add lignocaine 2% to it. So this is going to be the IV form for analgesia. And such patients also have reduced requirement of muscle relaxations, because this local anesthesia will lead to decreased production of acetylcholine from the presynaptic receptors. Then magnesium sulfate. This is again a part of this analgesia regime. Many people add lignocaine to PCM, and similarly many people add magnesium sulfate to the paracetamol to increase the efficacy of analgesia. So and also in patients, suppose eclampsia patients or pre-eclampsia patients, obstetric patients, they are on magnesium sulfate infusions, and for those patients the need for muscle relaxant will reduce. If you are using aminoglycoside antibiotics like streptomycin, gentamicin, they may prolong the effect. Verapamil, nifedipine, which are calcium channel blockers, lithium, dantrolene, and electrolytes like hypokalemia, hypocalcemia, hypermagnesemia, and acidosis, they all are going to prolong the action of neuromuscular blockade. These are very, very practical points where you should see if you're using any of these situations, the effect will potentiate. You have to reduce the dose, and you have to reduce the frequency of administrating the bolus doses as a maintenance. But there are certain situations we have to repeat it more frequently in higher doses. That is the antagonism of neuromuscular blockade. Suppose if you give calcium to the patient, obviously muscle contraction will improve. If the patient is on anticonvulsants like carbamazepine or phenytoin, they will induce the enzymes, and that will lead to rapid metabolism of these agents and rapid recovery from these agents. We are using theophylline or aminophylline. When do you use these theophylline and aminophylline? Suppose the patient had bronchospasm intraoperatively, and now to relieve the bronchospasm, there are several drugs, but very commonly administered drug is aminophylline. or the patient was chronically on theophylline because of asthma or COPD, those patients again will have faster recovery from these agents. Now the clinical scenarios, CKD. So in CKD, chronic kidney disease, we have a higher volume of distribution. There's a fluid overloaded state. So the loading dose of vecuronium and rocuronium is going to increase, which is very paradoxical. You usually think that in CKD patient we won't give vecuronium or rocuronium, but if you want to give them, the loading dose has to be increased, but the maintenance doses has to be given at longer period and smaller dose. So if at all you're giving vec or roc, this is going to be the regime. But obviously the best part is atracurium, because you can give it as much as you want, because of the Hoffman elimination it will get excreted. But the problem with the prolonged infusions, as we have discussed, of the lodanosine, which may lead to seizures. For chronic liver disease, as we know that rocuronium has a very extensive hepatic metabolism, so rocuronium should not be used. Vecuronium though can be used with caution, because of extra hepatic metabolism also and extra hepatic excretion. So vecuronium, if even if you're giving vecuronium, you should to try to give only 1 or 2 doses. If you are repeating vecuronium, because of a prolonged surgery, then the effect is going to be prolonged. So in that's chronic liver disease, the effect will be prolonged. So best is to avoid that and give atracurium versus atracurium. In infants, the loading dose is going to remain the same, but maintenance, because the metabolism is poor in those patients. So the metabolism and excretion, because of poor liver and kidney function in infants, the maintenance dose has to be prolonged. You have to give them at larger intervals, and that is why again the best formulation is atra versus atra in infants. In the elderly patients, because of the physiological changes, that is poor liver function, poor kidney function, reduced plasma cholinesterase activity, you should avoid giving vecuronium or rocuronium. Again, atracurium versus atracurium. So you can see that in most of those conditions, clinical conditions which are abnormal, CKD, CLD, infant or elderly, you are avoiding giving vec or roc and preferring atracurium. But because of the histamine release, you should remember that only two contraindications: think of seizure because of the lodanosine, and think of the histamine. So if the patient is asthmatic or hypotensive patient, already vasodilated state, try avoiding atracurium. That's all about the practical aspect of all those most commonly used agents like vecuronium, succinylcholine, rocuronium, and atracurium. If you want to read it in further detail, try to add these headings, and the topic of neuromuscular agents will be completed. Thanks a lot.